Hi, today I'd like to talk about benign or idiopathic intracranial hypertension, or you can also call it pseudotumor cerebri syndrome, and they are all talking about the same stuff. So, as usual, we start with a case. We have a 29 years old female came to your office, complaining she's having a constant headache and neck pain, which she feels pain behind her eyes. She's concerning on her vision gets darkened from time to time, and this pushes her to seek medical help. And she told you her BMI is 29, and a quick physical examination finds she's having a horizontal diplopia. So let me circle the important points for you. Firstly, a constant headache and neck pain. So when you say there's a neck pain, you have to think about there's something wrong with the neurology. So always rule out the important diseases. Have some physical examinations to confirm she's not having a like meningitis or those which is very fatal and have to treat immediately. And then she also mentioned, but this is not in our patients here. And then she's also mentioned she got pain behind her eyes, which we call this retro pain, which is pain behind her eyes. And then she got transient vision loss from time to time, transient. And then she's obesity. The BMI is over 29, so she's obesity. And she got horizontal diplopia. And this one you have to think about there must be something wrong with cranial nerve. And which cranial nerve, I'll talk about it later. Anyway, we have the clues here already. Although you already know which disease I'm going to talk about, but I think this one helps a good picture because for the causes of the primary BIH, benign intracranial hypertension, one of it is the woman at reproductive age with obesity. That's why I add BMI in this case. And then the other cause is PCOS, polycystic ovary syndrome. And then the other secondary cause, you may not have access to her medications, or she might forget about it, or she just come to you, or there's something wrong. So you have to also be aware and ask her for what medication she's taking or what disease she's having. For example, this antibiotics is for mycoplasma pneumonia or other infections like chlamydia, things like that. And then this one, vitamin A toxicity, and this medication, retinoids, is a vitamin A derivative. So, and this one is for acne vulgaris. And so you may observe from her faces to see if there's any need for this topical medications, and you can have clue if there's any secondary triggering medications, or maybe the patient is using growth hormone or linezolid, and this one is for endometriosis. So that's all like can see in many female patients. So you have to check their drug list or their past medical history, be aware of it. And then there may be also other reasons causing this intracranial hypertension, such as some cerebral venous disorder. And this have to be confirmed by MRI or CT. And then or other systemic disorders such as Addison disease, SLE, or hyperkalemia. And we have a short mnemonic for memorize what are the common causes of this intracranial hypertension. Female, I think there's some typo here. Female top. So female for the female sex, T for testosterone, O for obesity, A for vitamin A, and D for dinosaur. For the symptoms, I'll try to explain them one by one to let you not have to memorize them. So you have an intracranial hypertension, of course, it's going to be a headache, and I don't think this have to explain it. And then, because you have a high intracranial pressure, and if you know anatomy well, so you know the preoptic space which means the space behind the eyes is extend from the brain, right? So like, to be simple, like there's like a tunnel, or like they're connecting to each other, right? And so if there's increased pressure behind, which means the brain, so it's gonna affect the eyes. So the patient will feel pain behind the eyes. Yes, and since your eyes gonna be affected and have cranial nerve palsy, you have vision defects such as like darkened vision or diplopia or photopsia. And then I like to stressing on the diplopia, because the cranial nerve 6 palsy is quite common in this case, which is the abduction nerve. And then but this one is a very, very complicated topic. So to let you to understand it easily, I have unfortunately you have to memorize this one. It's a mnemonic. It's very useful. I use it since the day one I heard about this. It's like many years ago, but this one is very useful. I hope you all can memorize this one. LR6, LR for lateral versus muscle of the eye, and then SO4. SO will refer to the superior oblique muscles. And then O for others, which means other muscle of the eyes, except the two previous muscle mentions, are all responsible by cranial nerve 3. So cranial nerve 3 oculomotor. I think it's oculomotor. And then but in this case, we will focusing on LR6. So the abduction nerve. So there's high chance of the patient with BIH have cranial nerve 6 palsy, and how you can observe it from physical examination. First, you ask the patient to look at one direction. So you ask the patient, such as in this table, ask the patient look at the right side. So in this case, if there's affecting the right eye's abduction nerve, look at the right eye. So the lateral rectus, imagine when this muscle trying to contract and let the eyeball treats turn to the right side, and this part is not functioning. So when the patient is trying to look at the right side, it failed to respond. So the right eyes remain looking at front, and the affected left eye can turn to right side. And then when you ask the patient to look in front of him or her, since the lateral rectus, it sounds like it's not responsible for this action, but since this muscle is not functioning anymore, it cannot oppose the strength of the other muscles. So imagine it's like both sides they are pulling a string, and the right side, the lateral rectus muscle, lost the battle, and the other muscle outstring this muscle, and then they can pull the eyeballs to the other side, which they in charge of, so there's no unopposed force from the lateral rectus muscle, so the affected right eyeball turn inwards, which the unaffected left eye still remain, can look in front of the patient, And then lastly, you ask the patient to look at the left side. It's gonna be normal, because it's not the job of the lateral rectus, so of course you can look to the left side, and this is how you identify which cranial nerve and muscles is responsible during the physical examinations. And then the other is gonna have facilitated tennis, because it's related to the CSF. I think you have to memorize this one according to experience. I'm sorry, I can't figure it out, but it's according to experience, you kind of like understand why, but you cannot tell. Maybe there's some more experienced physician can explain this well, but not for me in this case. So gonna memorize this one, and then dizziness, and then neck or back pain, and then cognitive disturbance. So how you gonna diagnose it? Since I talk about many things about the eye, so of course you're gonna check on his eyes. So the first you have to perform is fundoscopy. It's like basic or difficult at the same time, but this is the very crucial skills for diagnose this disease. So this is almost like a must, and you have to identify a bilateral pupil edema, and then you may also check the visual acuity on or the visual field testing to check if there's any enlarged blind spot or peripheral vision loss. And then when there's like an increase, you suspect there's the increase in intracranial intracranial pressure, you may think of lumbar puncture. Yes, but like please remember you have to perform the imaging before the lumbar puncture to rule out the mass effect and structural cause. Because if the patients have like let's say a mass there, it is an absolute contradiction for lumbar puncture, because it's gonna cause herniations. So you have to remember always perform an MRI or CT to rule out such thing before you perform the lumbar puncture. And then which MRI you're gonna perform is you're gonna order is MRI with or without contrast, or MRI phenography. Why? I'm gonna explain this later, but in this moment, please keep it in mind. And if the patient cannot do the MRI, such as like have some metal implant or any other things else, you may order CT, like CT head with contrast, and also CT phenography. And then after you exclude this thing, and then you can now perform the lumbar puncture, you send the cerebrospinal fluid for analysis, and then you have to confirm there's an elevated opening pressure during the 25 and during the process. And this one is vital for confirm the diagnosis. And then there are two groups, which is one with and one without the pupil edema. So the group of BIH, you must fulfill all criteria, which means there's 5 of them, which are this here. And then you must fulfill, the patient must have pupil edema and have a normal neurological examination result except cranial nerve abnormalities, which I explained before. Usually the patient gonna have cranial nerve 6 palsy, and then it's gonna be a normal brain imaging. So you have to order the test to confirm there's an normal structure, and there's no any journal enhancement, no hydrocephalus, and then you can confirm, and then have a normal cerebrospinal fluid analysis result, and which means there's no infection or other thing else, and then gonna be elevated opening pressures during the lumbar puncture, and then the patient must fulfill all 5 criteria for the benign intracranial hypertension. But for the benign intracranial hypertension that without pupil edema, the patient must fulfill at least 3 of the following neuroimaging criteria, which, if you still remember, I said I will explain why you have to order an MRI phenography. This is here. Because one of the criteria is bilateral transverse venous sinus stenosis. Another one is anticellular, and then another one is threatening of posterior aspect of the globe. and the last one is the definite distinction of or enlargement of the perioptic subaneroid space, which I have prepared lots of images to explain what happened in the image. Then first one, the bilateral transverse sinus stenosis. So the anatomy graph here, you can see here is the transverse sinus, and then under the image you can see here already, there's already a right arrow here. There all is the stenosis here, and then this one is very clear and easy to understand. And the perioptic subaneroid space, what it is here. Perioptic means this here, this space. Subaneroid, it is like it's belonging to the subaneroid space, like what you learn from the brain anatomy, and then everything combines together is perioptic subaneroid space. So here we have a normal image, normal MRI. But here I have prepared those with enlargement here and here. I think this one is the T2 and the first T2 MRI. Yeah. And then a threatening cell. Here is usually displayed which the location of the pituitary gland. And then threatening means there's like maybe like a structural or like a defect, and then this display is supposed to be holding the pituitary gland, but somehow the cerebral spinal fluid managed to break through here. Not break through, but like this point is weak, and then so this compartment that holding the CSF kind of like goes down to take the space here. So you can see here looks like a fattening cell. I also prepared another coronal aspects of the MRI image. So here, you may try to pause and try to identify which one is the normal image and which one is the normal image. But anyway, this one is a circle. This is a flattening cell. As I mentioned before, the CSF is gonna occupy the space here, right? So CSF is fluid. As you can observe from here, this is a T2 MRI, and T2 MRI, which means the fluid is gonna be a bright white. And so here we can see very, very bright and white, like here. So it is supposed to be a gland and not supposed to be fluid filling this space. So you can like identify this enormity like instance. And these two are the normal image. Normal here is supposed to be here, a pituitary gland here. Let me try to use a pen here. And how can you identify the gland like immediately by looking at the MRI? You can, this is my personal experience, but you can look for these two. These two are the internal carotid artery. So you may also check the anatomy of the brain. And I recommend you can use some 3D model to help you to identify, and which is very helpful. But anyway, you can just by looking at these two arteries to locate the pituitary gland in the MRI image. And here, which also points out, this is like A for anterior pituitary gland, and this one P for posterior pituitary gland, and this I for internal carotid artery, and C here is this one is quite difficult to identify, so that's why I prepared an anatomy image on like with it. So this one is an aortic chiasm. This one is like view from the bottom, look like to the like you look from downside, look up to the brain. but this one is easier. But I think this wheel is easier for you and to understand the location of the optic carcinoma. Anyway, like this. Just imagine you look at it in a chrono assets. Anyway, I think it still takes practice to identify the anatomical structure, but this is not difficult. So I've also prepared some graph for you to identify the papillary edema. This one is, I think you may heard it like from everywhere, so I may not go deep, but if you are interested, you may pause and look at these slides, and I'll continue for the management. So the management of this patient, you have to contact neurology for the vision loss, because this one is very, very important. You may not handle it except you are the experts in this field, but I'll just call them. Anyway, so, and then firstly, like some of the other things you may think of conservative management. So you have to identify which medication is contributing to it, and then you have to seize it, and then manage the obesity and overweight problem if there's any, and then also if there's a PCOS, treat it, and then because the patient is experiencing headache and then pain behind the eyes, both eyes, right? So they may prefer to use pain management. Excuse me. So they may prefer to use painkiller. So you have to educate them on pain management to prevent overdose. You also have to monitor their vision routinely to see if there's any worsening or if your treatment worked. And then for the pharmacological part, you may prescribe the patient with acetazolamide, with its carbonic anhydrase inhibitor, and the alternative are the furosemide or topiramate, and they all serve one purpose: try to reduce the fluid volume. That in many ways, but in this case we aim for the effect to work on the CSF fluid, the cerebrospinal fluid. And this is short explanation, short description of what is the side effects, because I think this you may also have to be aware of, but it is hard to memorize, so as usual I will try to explain by the mechanism. So the patient might have some side effects of hyperventilation. How it triggers hyperventilation, and this graph since the since the acetazolamide inhibit from here, so it also interrupt the process of a series of process. At the end, it's gonna disrupt the combination, the reactions in here, instead of the sodium, instead of the carbonic ion combined with hydrogen ion to go through such process, they cannot, and then your body excrete carbonic ion, or not sodium alone, but like in the form of sodium bicarbonate. So your body is gonna excrete excessive carbonic ion and sodium bicarbonate, and then which caused hyperventilation, because when you lost this one is space, right? So like think of the acid-base problem. So your respiration system is gonna try to compensate for the acidosis causing by your loss of carbonic ion. So you're triggering a series of effects, there's like a chemoreceptor stuff, but you may look at it. I'm not gonna elaborate in this video. And then anyway, your respiratory system try to compensate for this metabolic acidosis. So you're gonna have hyperventilations, and you're gonna have acidosis like I explained before, and then this is a hypokalemic metabolic acidosis. How? Because because I said it's going to be excessive excretion of sodium ion, right? But this one is happening here. Be aware, happening in the proximal convoluted tubule cell, which is here. Your urine still have far way to go for a series of tubule of structures and then to be excreted. So it's gonna reach like your now imagine the urine of this patient is gonna full of sodium ion. When it reach the connecting tubule, the connecting tubule will try to absorb the sodium ion as much as possible by how? So the sodium ion is gonna exchange with potassium ion, exchange back into the blood, and then the blood gives out sodium ion into the urine and excretes with the urine. So the patient's gonna lose lost potassium ion, gonna lost exchange. Let me repeat again. The collected tubule is gonna try to reabsorb sodium ion by exchange the potassium ion, like the sodium ion from the urine into the bloodstream, and then exchange the potassium from the bloodstream out into the urine and being excreted. So it's gonna be a hypokalemic metabolic acidosis. And this one is hypoammonia with peristalsis. This one is it's gonna be memorization, unfortunately. And then why I spend so much time trying to explain, try to let you understand why there's hypokalemia. So to let you be aware of do not prescribe this drug if the patient is hypokalemia, and that's it. You just have to memorize one thing and you already understand the side effects and the contraindication. And then do not prescribe this medication for those with androcortical insufficiency, and then also the hyperkalemic metabolic acidosis, or those with hepatic disease or insufficiency. If your conservative management or medication is not helping the patient, I'm afraid there will be a surgery for the patient. But still there are indications, which is the rapid vision loss, or there's a vision threatening disease refractory, which means the treatments or other management is not helping the disease. So the patient will have to perform the surgery. What is the procedure is going to have is the cerebral spinal fluid shunt. And then there are two types of shunt, which is one is the LP, the limboperitoneal shunt, or the ventriculoperitoneal shunt. As you understand by this name, you can already know where's the origin and where's the shunt gonna it's gonna the tube is gonna insert to where and then goes to where. And in this LP shunt, it's gonna insert from the numbers line, and then the tube is gonna guide the fluid to excrete out into the peritoneal space. And the same for this one to this one. But it's difficult to understand by just talking about it, right? So I've also prepared images for this one. You can also Google some surgical video that will help you to understand what's going on. And this one is for the LP shunts, and this one is for the VP shunts. And this one I recommend, and I will also include the link in the introduction. This one is a very, very good footage of how to perform this surgery, and by the channel of Brainbook. And this is a wonderful video, and I suggest everyone who is interested, and this help you understand what's going on for the procedure. And this is all for this video, and I hope it helps. And thank you very much for your listening.